physician who works closely with marginalized and medically vulnerable patients, and one of the most visible physician voices in Canada's MAID debate. She has testified before parliamentary committees studying MAID, written extensively on the issue, and serves as an adjunct research professor of family medicine at Western University, and is a senior fellow at the Macdonald-Laurier Institute. In today's conversation, we examine what she's saying is happening inside Canada's MAID system, how vulnerable patients may be affected, and what kind of medical and moral culture this country is building. Dr. Ramona Coelho, welcome. So glad you're here with us today. Let's jump right in. So you're a family physician and you care for disabled, poor, and very medically complex patients. And before we get into things like policy debates and some of the politics around that, I'd really like to know, what were you seeing with MAID around the time with your patients' lives and their care that sort of made you feel like you started to need to speak out about this?
Well, thank you, Mark, for having me. I like you said, I've been taking care of people with complex issues for many years. For almost 20 years now, I've been in practice. And I've been dealing with, in my regular care, death wishes my whole career, trying to help people have solutions to mitigate that suffering. And when MAID came along, initially, I wasn't too active on the political front. I was concerned that I'd be able to continue taking care of my patients, like in terms of conscience rights, but otherwise I was pretty not involved in the debate. And then I started to see that this issue was going to touch my patients more than I had anticipated. I read the legislation for the 2021 expansion to people with disabilities who are not dying. And in the legislation, I could already read that there were certain things I considered to be issues, that you had to offer people options, but they didn't have to be accessible or tried, that suffering was deemed intolerable, but was totally subjective. There didn't seem to be an objective scale or a time to kind of try to mitigate it. 90 days, I was concerned because for my patients, it takes a lot longer than that sometimes to deal with very intense suffering, but we do deal with their suffering. Wait times to see a specialist can be long. Then there has to be trials of care. So I was concerned about that timeline. And then patients started to get offers of MAID, my own patients. So some patients already, if they had gone to the emergency room, could sometimes, in a rushed emergency room, can sometimes be sent home even if they are sick, and you have to kind of like advocate for them and send them back, especially some of the patients that I take care of. But it turned out that some of my patients were being offered MAID immediately when they found out they had a new diagnosis. I had a cluster of patients who had new dementia. They still had a prognosis of 7 years or more. They had very mild findings. This is really the beginning of their journey, and they were terrified. And the geriatrician had written in the consult, "Well, Dr. Coelho, they said that they're not sure they can live like this, so I have connected them to the MAID team." And I'll share, as I've shared many places, that I've also cared for my father who has dementia, who lived with me, who died a year ago, last March. And also I used to do dementia care at the CLSC in Montreal. And so even just with being able to work with them and explain to them how we could cope and how people can live well with dementia and how I would be there for them, they decided they didn't want MAID, but they were already approved for MAID within 2 weeks, both of them, both under track 1, even though they're both alive today. And this is like 6 years ago, I think. And they were not offered options there were no concrete options in place. This is like first diagnosis. I had another family where this lady had a liver cancer, and I have a lot of palliative care skills. I had done home care in Montreal. So actually, the palliative care team was not actively involved. I was taking care of her. We were managing her pain and her shortness of breath. Those were her 2 main symptoms, and she was doing quite well. Her family had taken time off for their last days to go through photos and spend time together. And home care booked a half day to talk to her about MAID. And they all called me after. And they were like, well, we've booked the MAID assessment in the morning because you apparently wanted it and you sent this team to the house. And I said, I didn't do that. And what do you mean? They were pretty angry. They were angry and they thought that I wanted this for them when they were actually enjoying the little time they had with their mom and they wanted that time. And actually, she died 2 days later, so they felt like they were robbed of half a day. And they had felt pressured because the power imbalance of being offered this to have that MAID assessment. And I had told them, you can cancel that. And I didn't set that up for you.
Who offered or arranged that MAID assessment?
I guess it was home care that was wanting to inform her of her options. And so I don't know if it was a social worker who went to the house to talk to them. And I had a patient who had a relatively new spinal cord injury, no time for adjustment, was told by a MAID provider she could come back whenever she wanted, that she would qualify. And anyways, I started speaking about these things, and then doctors started connecting with me about cases of concern. And that's what I ended up speaking in Parliament to share these cases. And it really hasn't stopped since then.
So, I think that you've witnessed the introduction of MAID as a physician in practice. And if we consider track one, which was the original legislation that was offered to Canadians as an exceptional measure for, exceptional cases of suffering, but that's now kind of rapidly shifting. In your view, what is MAID becoming?
I think, I was just involved. I've written an article in BMJ about safety in MAID. And
That's the British Medical Journal?
Yeah, the British Medical Journal of Supportive and Palliative Care. I wrote an article with the coroner of Ontario's cases that he released. And in that, I talk about the drift that I think is happening. And part of, I think that we've had very little kind of corrective measures in terms of how MAID is implemented. So you have certain MAID professionals, clinicians who do an excellent job. They self-regulate themselves. They will look for other options. And then you have a very small group of MAID providers who potentially have a very lax interpretation of the law. And no one is really correcting that drift. And so patients can shop until they find those few MAID providers. And I think that in my opinion, there are proving cases that the rest of Canadians, the rest of their own MAID community, the rest of our medical community would not consider to be in keeping with the spirit of the law.
So we hear so much these days about quality assurance in medicine and medical care. What are the quality assurance measures looking at this whole process and a reassessment and a reevaluation using real live data in terms of where and how the process is evolving? Are those measures in place?
I would say they're not. So the government did not legislate that any special training happened to happen for MAID assessors and providers. So any physician and nurse practitioner can be a MAID provider in Canada. They do not have to do any special training. Alberta has just tabled a bill that would enforce training before becoming a MAID provider, but otherwise, no. So you had a lot of people joining on who wanted to help this along, but might not have had chronic care skills. You had...
but aren't assessors... I've heard that assessors go through some training to become assessors, but by that you mean they have no experience in the field of palliative or other rehabilitative care?
No, they have no
Really?
training. No, so I'll tell you. So basically, the government did give a certain amount of money to CAMAP, which is the Canadian Association of MAID Assessors and Providers, and they have developed or are in the process of optimizing their curriculum that can be offered. It's not mandatory, it's CMEs. You have people like David Henderson, Nova Scotia Health Authority, who has shared in parliamentary hearings when he was called that he's very concerned that a lot of MAID assessors in his area do not have he's a palliative care doctor by training, that a lot of them don't necessarily have that kind of palliative approach, evidence-based approach to chronic care or symptomology, like managing symptomology. And a lot of them, he offered to create a curriculum. This is just a local story, but just to explain, and it was declined because he was told it would be too time-consuming to do that. So you have some people who are very motivated, who want to learn, who will learn the best evidence to how to mitigate suffering. But then actually you don't have a standardized training program across Canada. So that can lead to potential, like I said, drift of certain lax providers. And you have Alberta that's moving towards enforcing training to be a MAID provider.
So I remember hearing about how there's sort of very firm belief among leadership nationally that standards are in place and this is all going to be covered by standards. Is that the case on the street?
No, it's not. And I think that's been I try not to be political, but it's been very difficult because the government, even in the parliamentary hearings that are ongoing, what they want to hear is that we are professionals. We will get this right every time. Trust us to do the best job. You have CAMAP and Pasut and Al publishing in CMAJ saying, yeah, there's wide variation in how we practice MAID and what we believe, but let us figure it out with MAID consensus internally. You have the disability community. I know that you had Krista Carr on a previous episode, who have been trying to share their experiences, even under track 1 of people getting MAID because of long-term care, forced separation from their families, lack of resources. And you have the government, I suspect, that doesn't want to lose face, who just keeps saying, like, we have standards, there's no issue. The thing that we hear often is, like, there's no police charges, there's been no college issues, so there's no issue. And for me, I understand. I have friends who are MAID assessors who are doing a good job, like according to the legislation, whether I agree with the legislation or not. But there are others who are not. And trying to pretend that there are no issues because of the polarization of this debate really leaves the disability community in a bad position, in my opinion. So that when you have people who have transient suicidal crises, just like me or you would have, you have people looking at them saying, yeah, I totally agree. If I were you, I think it would be totally compassionate to end your life. And so in very short order, ending their lives. In terms of quality assurance, in terms of that question you asked, every province has different legislation. So even though MAID is a criminal framework, it's a exemption to homicide and assisted suicide. It's carved out federally. You have each province enacting medical legislation in terms of how MAID will happen in each province. And Ontario, I would say, has the best oversight. Our chief coroner of Ontario was mandated to have oversight of MAID, and he has a team of specialized nurses called the MAID review team, and they review all cases of MAID in Ontario, and they give feedback to MAID providers if they think there were some medical issues. There were some complaints, like in the media, about how, feedback is great, but if it's not changing their practice and there's no enforcement, that's problematic. That's not the coroner's fault. He doesn't have the ability to sanction them. I think he could refer them on to the police or the college if he wanted to, but he does a lot of great teaching. And so I think Ontario has the best model, but it still doesn't have sanctions. And so I would say that we have the best quality assurance, but whether that leads to correction will remain to be seen.
Part of this is generating some conversation around an issue that's, people think about all the time. I think it's on the topic agenda of things that people consider when they're sick, when they're unwell, and it's not surprising that there are lots of opinions out there. But getting back to track 2, which has been the expansion from the original indication where death was imminent, are we seeing an increase in the growth trajectory of the number of track 2 cases?
Yeah. So actually, I just want to say for track 1, just so that people understand, it was never about imminent death. So Canada already had a very broad legislation from 2016. We had reasonably foreseeable natural death. And that has been interpreted, as I said, because it's not easily medically translatable, it has been interpreted as weeks to months by some MAID assessors and providers, and some up to 5 years prognosis. And track 1 allows for same-day death, and we can talk about that. But in terms of track 2 and in terms of growth in general, there's been astronomical growth in Canada. I would say, Health Canada would probably frame it differently than me, but year after year we were seeing like 36% increase in MAID totals. The last years, our last report is the 6th annual report on MAID, which came out in for 2024. So it came out in December 2025, reporting on the 2024 year. And I think it showed a 7% growth increase of all MAID. And I think the numbers for track 2 went from 450 to 750. You have to look those up for sure, but I would say that the increase is quite substantial. And already in track 2, like I said, some MAID providers are calling that 5 years. It's actually in Pursuit and Al's MAID assessors and providers scientific research that she published in CMAJ last month, I think. So that is from the MAID community themselves. But for track 2, you don't have to be anywhere near the end of your life. So you can have people in their 20s or 30s with fibromyalgia. You can have people who have social vulnerabilities. So in terms of the MAID Death Review Committee, which again like I said, the chief coroner has been doing oversight of MAID, but he decided in the beginning of 2024 to enact a MAID Death Review Committee on top of his MAID review team. And I'm one of those members. There are 16 of us on a panel. And his team selects cases that we look at the cases, review them, and then lend our expertise in terms of public safety for him to make reports that he's published. They're out there with the cases and then his recommendations. And in the track 2 reports that came out in October 2024, you can see that track 2 cases had more women than men, tended to be poorer people, tended to not have a next of kin. So like for me, already we know from the Health Canada reports that loneliness and being a burden, what are those? For me, those are societal neglect, right? The people we have failed to make them feel included in community. But in the track 2 reports, like in terms of looking at like statistical evidence, many of them could not name a family member as their next of kin. Some of them naming their doctor or their lawyer. To me, that speaks of social isolation. If you look at the treatments they were offered before they got MAID, on 99% of them got medicines, drugs. But only 50% of them had been offered disability or mental health supports, and less than 10% had been offered community solutions. As somebody who has done chronic care of vulnerable people, often housebound in my life, most of them have benefited most from mental health supports, disability supports, and community solutions. And so I find that very worrisome.
So, as we approach the 100,000 number for MAID in about a decade, you've certainly said that marks a quiet but very profound transformation in how medicine understands suffering and autonomy and its own purpose in this. What has changed here, or is changing in real time, that Canadians are just not realizing that we need to acknowledge?
Well, there was a very interesting study done by Choi et al. It was published in BMJ Open. It was an NIH, like a National Institute of Health study of Canadians.
From the States, yeah.
Yeah, but it was a survey of Canadians to see what they knew about medical assistance in dying. And what it showed is that the majority of Canadians in that survey strongly support medical assistance in dying. But the survey followed up with cases that are actually happening in Canada that are legislatively allowed by our framework. And actually support for medical assistance in dying in those cases fell a lot. So it means that I think that most Canadians, even though they strongly support medical assistance in dying, they think of it as you mentioned, imminent death. First of all, it was never about imminent death. They think about it for people that we have tried everything that we care about and we have really failed, and so we're offering this option. And that's not actually the case. That has never been the case. Our legislation is much broader than any American jurisdiction's approach to MAID, or they say assisted suicide because they self-ingest their meds. They have a much tighter prognosis. In the Netherlands and Belgium, even though they have problems, and actually it's Carter, the judges said we would never be like them. They actually discounted evidence from Belgium because they said we would never have such a kind of open approach. They still have to, in most cases, say that everything has been tried and the patient has not responded.
So tried, not just suggested.
Yeah.
But tried.
And as you said, like as I pointed out in the track 2 cases, what are we offering people before we offer them death? We have another report, a dementia report. And again, my father died for dementia, so this one. And he died, he was dying as that dementia report was coming out. It was very sad for me. That of the people who received MAID for dementia, they were citing fear of decline in the future, fear of being burdened, things that we should be comforting people with. We should be offering them existential psychotherapy. We have Harvey Chachanov has, he is like a pioneer in the world in creating dignity therapy and letting people understand that they still have value, even as their lives change, to help them adjust to illness and injury. Yet, people received MAID, only 13% of them had been connected with palliative care before they died. That to me is a human rights failure. That we're not offering care first, that this is not really an exception. And I am disappointed that Canadians don't know. It's not their responsibility, but it's not been very high in the public interest either, I would say. And because there's a lot of polarization, you can have unkind players on both ends of the spectrum that can make it more difficult to have what is a very complex debate. But I do think that people are allowed to have their opinions on both ends of the spectrum. I'm talking about unkind players. I think people are allowed to have their positions, but then we have to bridge. And we have to bridge with reality and what's actually happening. And these cases are actually happening. It's not helpful to anyone to have certain groups saying that to the disability community, basically they're saying they're all liars. Not okay. Not okay. This is the community that the UN has said is marginalized. We don't meet their needs. We don't meet their healthcare needs. We don't include them in society. We don't have the accommodations they need to get into most places to actually be able to connect with people. And then that is the one group that we offer death. And then we say, no, your stories are fake. That's basically why I got involved. Because, it's very sad, but in terms of discrimination, people have a harder time when medical experts get involved, even though I'm only saying what the Indigenous and disability community has been saying from the beginning.
So are we at risk, or is there this looming risk of heading towards euthanizing the poor and disadvantaged in Canada in the name of compassion?
Well, like I said, I think it's pockets of providers. There was actually an Associated Press investigative journalist article that came out by Maria Chang and Angie Wang in 2024, where they were given access to MAID providers' private forum, where MAID physicians were talking about how distressed they were but felt compelled to do these cases because they fit the legislative criteria and patients really wanted them. So I'm not blaming those doctors, but I don't think that that's what the legislation intended. Like, I understand that there's no definition of suffering, but really, like, poverty, that's not irremediable. If we cared to fix that, we could. Housing insecurity, loneliness, going into long-term care. What does that say about the state of our long-term care? And is MAID not, because MAID is lending a life, is that not further neglect? When we're saying that we can't offer them a better situation, and so we will offer them death. There was a case in the MAID Death Review Committee of a woman who is in her 60s, I believe, and she's obese. And that was also part of what was leaked in the Associated Press article through the forum of MAID providers. And this lady was disconnected from care for years. She was housebound, and she had a history of depression, but she had been off her meds for several years. She requests MAID, and she refuses any workup to figure out what her actual prognosis is, how she would do. And the MAID providers approved her, and this is a MAID Death Review Committee case that's been published. The MAID providers deemed her as having a grievous and irremediable suffering with a reasonably foreseeable natural death because she would refuse any treatment anyways if she got sick. And a reporter asked me about this case. Well, it's her choice. People are allowed to decline care. So wasn't it compassionate to offer her MAID? And, this is where I feel like there's like a little bit of disconnect. I'm not talking about the reporter. I'm talking about everybody in general. And like some of us have had these life experiences that are changing for us. But when I did home care, I was called several times into homes of people like where they'd gone to do work in the apartment and realized this person was in a total state of neglect. There'd be like feces on the floor. There could be papers. There could be hoarding. There could be lots of things. Total social isolation, not malnutrition. And sometimes these patients wanted to die or they wanted me to go away. Either one, right? So now it sounds like they found a similar patient in the time of MAID and they offered them MAID. So what would I have done if I had met this lady when I did CLSC Metro Home Care or like the other patients that I met? I would say, please let me be your friend. Please let me come back. Let me get to know you. And actually, I would like to send other people from my team. They're really nice people and they'd like to just have tea with you. Right? And we would send in the social worker and we would send in other people and I would keep going back and we'd be building that relationship as long as they would let us in. That is what I consider good care, right? You build up that trust and then eventually you get them re-engaged with care. You reconnect them with community. That is the appropriate response to someone in that state. But saying, well, you're not going to get treatment anyways, so I'm going to give you MAID, to me is just a worsening of the neglect that they have found themselves in for whatever reason. People say, and that's what really concerns me, people say this is autonomy. Autonomy is a fragile concept. And some of us have more choices and therefore more freedom in our autonomy to make choices than other people. Some people have been dealt a really shitty card, like a really shitty hand. And it's our job to help them repair that. It's not, I think that when we say like, I care about what I hear and how I interpret this is I care about you so little that I'll help you end your life. I know that's not their approach, but this is how I see it because I have accompanied so many people and you can't help it. When you do chronic care and you follow people for years, you learn to love them, right? You know them. They know you. They're like, it's to me, it's very personal. This is not true love to end someone's life when they're like suicidal and in a state of neglect.
So, Health Canada's own data shows that loneliness, fear of being a burden, like you alluded to, and existential suffering are major drivers in the emergence of more and more Track 2 cases. Why is the answer here to those conditions increasingly death instead of care? And when those are exactly the kinds of suffering that, medicine and community are actually supposed to respond to. Why?
I can share a personal story about that. Yeah. Well, first, it shouldn't be so easy. I think that the government has had a failure here, a major failure. I'm not talking about the MAID clinicians. I'm talking about the government in terms of the lack of willing to correct or willing to mandate teaching or other kinds of things. But, what I think is I said, it's very personal to me, but it's also personal to me because I could see myself in a different time having made very different choices if I hadn't accompanied those patients for a long time. So when I started practicing, and I shared this on a different podcast, I was given the care of people with very severe disabilities. And I felt scared. I felt scared. And I started to project my own fears, uncertainty of what would happen to them and about their death. Those fears created what I call, or what has been called in evidence, therapeutic nihilism, right? This understanding that I can't fix anything here, nothing's going to get better, and maybe it would be better if all this just went away for all of us. And I shared that I probably had a major depression or an existential crisis. It's hard to know now. But part of that therapeutic nihilism, which I think is a very natural response, and I think a lot of Canadians are scared of disability as well. And so the thing is, it can feel like a compassionate response if you don't have the learnings and potentially don't have the psychological maturity, like you haven't actually lived through that to understand the evidence that people largely recover, right? If you look at the evidence on major illness and injury, most people by 2 years rate their quality of life as the same as age-matched healthy individuals. But now, in that time of crisis, we can end their lives with MAID. And so we absolutely need a correction here. Who it comes from, I don't care. If it comes from the MAID community and the clinicians who are evidence-based helping their confreres, great. But I do think that for the protection of Canada, there needs to be some sort of external group also providing oversight and making sure this is not just any program. This is a program to end life. And it's been, for better or for worse, it's been inserted in medicine. My husband's a surgeon, and can you imagine if he's a kidney cancer surgeon, but anyways, but imagine that he was doing amputations and he was offering them for things that could be treated otherwise. That would be unacceptable. He'd probably have lost his license, and rightfully so. We would all understand that. But there seems to be a hard disconnect, and I think it's because of that nihilism, or people could call it discrimination, call it what you want, but you see people who are with disabilities and that fear that you think you never want to be there, you would just be compassionate to offer them death. That needs to be corrected.
I wanted to switch gears a little bit and sort of talk a little bit about some of the illustrative cases so people can understand a little bit better of what you've seen and what the reviews have shown. Some of your research has flagged track 2 deaths among people with no fixed address. Now, how is it possible that homeless people could be dying under a system that actually claims to have safeguards?
So actually, that stat was pulled from the Health Canada report itself. And so I don't have a lot of data on that, but the Associated Press article did speak about MAID also in that leaked document about MAID for people with housing insecurity. So we do know that those cases are happening. We do know that there are cases of people who are their needs, the suffering is not from their disability. In fact, the previous president of CAMA said in an interview with Megan Gilmore for the Canadian Affairs that the legislation doesn't tie the suffering to the disability. And so you have some people interpreting that as it could be any suffering. And we know that homelessness, financial insecurity, loneliness, all of these things, they are real suffering. I mean, no one's going to deny that they're real suffering, but I don't think the intended legislation was that we would end lives for that kind of suffering.
So on the theme of safeguards then, identifying individuals in this predicament, shouldn't there be built into this whole system provisions for something like a crisis team for these types of track 2 requests so that there's expedited access to the care that's truly needed to help start the process of turning things around for these individuals who are otherwise at risk of death, potentially?
Yeah, I couldn't agree with you more, Mark. I'm friends with David Shannon. David Shannon is a gentleman with disabilities. He's also won the Order of Canada, Order of Ontario. He's a human rights lawyer. And we have written an article about needed legislative safeguards that could potentially make this regime safer. I personally, I'm with the United Nations that Track 2 needs to be repealed. That if you look at the stats, like the question is like, it's a public policy, right? So one has to decide how many wrongful deaths one thinks is okay before they stop a program. Because it's not about suicide. Suicide is a right. We've decriminalized suicide. People can commit suicide. It sounds very harsh. I don't want people committing suicide. But this is our society helping people end lives. And I from the stats, from the stories that I've seen, I find Track 2 very dangerous. I actually think there have to be a lot of safeguards put into Track 1. That people can have same-day death, again, with rushed assessments, without having access to palliative care, when they have clearly, in my opinion, and from the documentation, lacked capacity. These are also really problematic. And I think also, there's two levels of things that we're dealing here with this MAID program. You have a group of people who want compassionate access to death, but we have to balance it with the safety of vulnerable Canadians. And a lot of people say, well, these are white, elderly, wealthy people getting MAID, therefore they're not vulnerable. I'm so sorry. I used to do part of my CLSC home care in Westmount. When you're near the end of death, it doesn't matter how rich you are. You can still have vulnerabilities. You can still have, unfortunately, family and elder abuse is very high in Canada in general. In the MAID Death Review Committee, you have cases of families raising MAID repeatedly to the clinical team, not the patient. Patients who have documented pretty severe cognitive changes who, under the current law, shouldn't be getting MAID. The family is saying they want MAID and they're getting MAID. You have patients where there's caregiver burnout involved and the family is calling the care coordination service for MAID assessments when the patient has clearly documented the day before that they didn't want MAID. So everyone's allowed to have their own opinion, but just to be very honest, I think we need to get rid of track 2 and we need to fix track 1.
It sounds like just a deeper lens looking at those situations when it comes to talking about safeguards and sort of prophetically saying that the safeguards are there, they will do their job. And you hear more and more stories where, acknowledging the reality and that these things have happened, the safeguards need to be better developed, or as we alluded to earlier, the quality assurance and reassessing and taking the time to reassess where are we at now? Is there a problem? What do we do about it? And how do we reassess for being successful at implementing those changes? You described, or maybe you alluded to it a little bit earlier, where a patient was vigorously roused from a state of sedation and sort of getting rough ideas with nodding and sort of mouthing yes and blinking that they were willing, and that was sort of considered consent for MAID. Can you take us through what happened in that case and how,
and that's
in terms of the principles of consent, how that could be considered valid in Canada?
Okay, I don't think it's valid. I just to be very clear, but this is a documented case from the coroner. So the chief coroner actually in 2020, is not public at the time, but he gave a presentation to MAID providers saying that there were documentation problems with capacity, that there were patients who had clearly documented incapacity by the treating team or were delirious from the notes, and that somehow the MAID provision happened anyways, the MAID assessments happened during those times, and there was no standard capacity assessment done. To do a capacity assessment, it has to be issue specific. You have to show that the patient understands and appreciates what this choice is and what the other options are, and that they can reiterate to you their reasoning and understand. You have to make sure that their insight and judgment is intact. There's lots of things that go into a rigorous capacity assessment. And in terms of capacity, there is usually a presumption of capacity in everyday life, except that as the stakes get higher for a medical decision, as you and I know, it's really important that capacity is assessed. So I will share that when my father had dementia, unfortunately, was not making a financial decision. My father was very high functioning in terms of presenting himself for 2 minutes, even though he thought we were still in India now and lived on a cruise boat. It was pretty amazing how, anyways, we had to get him declared incapacitated for his finances. And Ontario has, you have to hire a capacity assessor who's been trained and certified by Ontario. They have to come to the house. They had to meet my dad separately and then us and actually look at the finances and find out what was real, and all of this to protect my dad, which I appreciate. But the standard of financial capacity assessments is very high. Right? They decided my dad did not have financial capacity, and so the POA for my mom was enacted. For MAID, one could say that the stakes are just as high or higher, right? We're talking about life and death. And so in this case that you're talking about that was published by the coroner, and I wrote an analysis of it in an article, I think, called Rushing to Die. This gentleman had made MAID inquiries. So it's not like he had actually had MAID assessments. It's not that he had met an assessor and talked about his suffering and been approved. He had made MAID inquiries. And then he became delirious, as according to the documentation of the treating team. And actually, he was made comfortable. His POA was enacted. His substitute decision maker was enacted, meaning that everyone had acknowledged that this patient didn't have capacity, and he was being prepared for a transfer to hospice. A MAID assessor shows up and says, "Well, I think he wants MAID." I'm paraphrasing now because I don't have the case in front of me, and withholds medication to try to make him more alert. Shakes him, like rouses him to try to get him to open his eyes, accepts, nods, mouthing yes as confirmation that he has capacity and that the assessment is good enough to do under those conditions. Facilitates a second virtual assessment that way, and then the patient's life is ended through MAID. I don't think in any way that fits the capacity standard in Canada. I do not know if the chief coroner put the case forward. We don't know those kinds of, we're not entitled, like as the MAID Death Review Committee, we're not entitled to that kind of information, like if there was an inquest or if he was reported to the college, I don't know. But I think it's very clear I'm sure you understand too as a physician, that doesn't meet the standard of capacity. And currently, MAID is supposed to be a voluntary decision where there is capacity.
You also describe or speak of a patient saying that she would rather die than live in poverty. But by definition, that's not a medical crisis. And it's a social crisis. And when a patient says that to you, and hearing it as a physician or as a citizen, like, what does that reveal about what the system has become or is at risk of becoming?
Yeah. This is what I'm concerned about social messaging in general, Mark. So in terms of suicide prevention principles, the strongest one that we have is that messaging affects our choices, which is why the Indigenous leaders are so concerned, right? They have a suicide crisis amongst their youth. And what is the strongest prevention tool that we have? It is the message that death is not the answer, suicide is not the answer to our life suffering, that we can overcome life suffering, that there can be hope. So when we start to introduce very broadly into society that actually for a certain group of people, death could be the answer, we are potentially doing what we know suicide, the opposite of what suicide prevention does, is suicide inducement to suicide. So when Robin Williams committed suicide rates went up in America. When a youth commits suicide on an Indigenous reserve, the community has to be really careful and try to really attend to their other young, because the rates of suicide after that, they go up transiently. When people have access to pesticides or guns or bridges, there is increased suicide rate. And these are like, if you put up guardrails, we know that suicide rates go down. It's not like someone walks over to the next bridge and jumps. But here we have a program that offers a compassionate, lethal means, like embedded in medicine, very attractive, and is being given to patients. That patient of mine had a spinal cord. I mentioned her earlier, actually. She has a spinal cord injury, and she let me share her story. I shared it in Parliament. She can walk, but she's lost some of her other functions. She can't lift. She used to do more manual labor. She would rather die than not be able to afford to live well. And I just step back from her because I don't want this to become all about her. But what I'm seeing is patients who are saying, well, MAID is legitimate. I don't want to go see a mental health expert. And it's very difficult when MAID providers are telling some of my patients that they don't need to, that it's their right. Like, that is not the legislation. If you actually read the Legislative Health Canada's like write-up, not in the legislation, The intention is not to refuse all treatments to automatically render yourself eligible for MAID, right? That is suicide. And yet you have some MAID assessors telling my patients, yeah, you don't have to do that. And like as in the case of this lady. And it becomes very difficult to offer care when you have these competing principles. You have someone else kind of saying like, hey, come here, I'll take care of you. I really care about you. I'll end your life. Don't worry about that treatment. It can be very difficult then to do the hard work. It is hard work, right? It's not hard. I don't know if you, I have personally, like I shared, had a depression myself. I've been suicidal myself, very ambivalent. I would have been very happy if a bus had hit me when I was doing home care those years ago, for many years actually. And the idea that someone would be there offering death to a certain group of people when they have their downs, not understanding that it can still be mitigated, that it can still be treated, is very worrisome to me.
You've talked of some cases where a disabled patient in hospital was feeling medically neglected and sort of even felt humiliated and being left hungry, just in a state of decay and still moving through the MAID process. Now, who's supposed to protect the patient in those scenarios where the care provided by an institution in itself is actually wearing them down, making them see MAID as being more appealing?
So in that case, that's one of the cases where I gave a talk and the doctor involved in this case called me, not the MAID provider, but somebody who is associated. And he said, Dr. Coelho, I have to say, I thought you were a bit over the top. He's like, I heard you give a talk of what you're worried about in the legislation, but we're all professionals here. He said, except that there's this case, and I have taken care of one of the family members for years, and I know this family. And this patient was also delirious, and he had his MAID provision booked before he had his assessments, and he was separated from his family during COVID. And could you help? That's how I got involved in this case, unfortunately, after he had died. And I offered kind of support to the family, who basically have a lot of PTSD from what happened. But a lot of the cases I spoke about in parliaments and so became public were also during the time of COVID. So add on that layer, Mark, of them being separated from their family. They're not allowed to have that many visits. This gentleman was initially, he came in, I think he had a fall, and then they put him on the COVID floor in case he had COVID. He caught C. difficile while he was there. So these are all acute things, right? I don't think we should be offering MAID for someone when there are things that are acute. It also affects our voluntariness. So like when we talk, someone could have capacity, but if you are in a state of acute suffering, that might not be the best time to talk about death. And yet someone, when they mentioned to him that he wouldn't be able to go back home, that he'd have to have a longer rehab admission, they said, or he could have MAID. And so all these things affect voluntariness. And then our system failing people also adds on to that in terms of affecting our choice. Again, it comes back to like, is this really just about autonomy? Or can we understand that life is a bit more complex than that? And that there are different constraints. If no one had offered him MAID during that time, it would still be a horrible memory, but at least he would have come home. Maybe he would have still chose MAID when he was stable and later, but we will never know. And also, I strongly question whether he had capacity. I do not believe he did. Like he was so sick during that time that there was, from what I understand, he was delirious. Many failures there.
You mentioned something that sort of really struck me, and that's the distress the families sometimes experience, and even to the point of having a PTSD-like reaction. Can you comment further about family and caregivers of patients pursuing different avenues with respect to Track 2 and MAID?
Sure.
What is the impact on families and caregivers?
I'm sure it's very diverse. I'm sure it depends on how the family is, what their values and preferences are, and how they perceive MAID went for them. There was an article that came out of Joint Center of Bioethics, and they had used CAMAP, so like a pro-MAID advocate, like scientific group, to acquire the families. So, you wouldn't think that these are people who all hate MAID. And they interviewed these 12 families, and then they wrote up their findings. And 1/3, so I guess that's 4 families, thought that MAID was amazing, that it was a dignified death, and they were so happy their family had access to that death. But 1/4 found the procedure in itself traumatic, that it wasn't peaceful, it was either rushed or the person was in pain and they weren't comfortable and there were other things going on. And then 1/3, the last 4, found it was undignified because it was driven by socially unjust reasons. And that's very hard. And actually, that's an older study, but a newer study just came out literally, I think, 15 days ago, so like at the beginning of March, from a group of University of Alberta researchers on family perspectives of MAID. And Sharon Kirky published an article. The reason I know about this is because she interviewed me for her article and sent me the link to the study. So I read the study. And, again, diverse responses, but a significant amount found that it was a rushed assessment where, the patient, the patient didn't necessarily have like a deep dive of their suffering. They weren't sure that all options had really been covered. There was virtual assessments that they felt were inadequate, and some reported in that study only finding out about MAID of their loved one after the fact. And the reporter had asked me what I thought about that. Like, should families, I think the question to me was, should families be able to veto MAID deaths? And I said, I don't think it's that families want to be able to veto MAID deaths. We have certain laws about autonomy. But I think families want to be involved because they are a necessary safeguard. They can offer information, for example, about past suicidal things, about options that have not been explored, about ambivalence. They can add a certain layer of, not all families, but a lot of families could do that. And a lot of families would just want to know that really this was actually a good medical choice for the family. It is going to affect them. And so I ended up accompanying, after I spoke in Parliament in 2020, I have ended up accompanying not a small group of families. I have been connected by lots of reporters of distressed families, and lots of physicians with distressed families. And so part of all of this is also becoming a support for families who have an incredible level of trauma. And what I'm really concerned about is like how many people, because all of these people were very pro-MAID, and potentially in principle are pro-MAID, but now do not feel like it's a safe law because of what's happened to their family member. And so the question is, like, when I circle back to the Choi et al. Study, which showed that most Canadians don't understand what can happen in our MAID program, how many people will it take for there to be changes, for there to be the will to really change this program and make it safer?
We're going to take a break there, folks, and we'll be back shortly with more interesting conversation with Dr. Ramona Coelho.
One of the things I noticed when I was researching this story, particularly for the episode with Krista Carr and yourself, is how the language has shifted. There seems to be a control around the language we're using, which seems aligned with sort of the pro-MAID agenda. Initially, we were talking about doctor-assisted suicide. Now we're using the acronym MAID, which is much cleaner. It's avoiding all the trigger words. Suicide isn't in there. We're not referring to death directly. So we've got this sort of clean use, a shift from some of the more sort of triggering or difficult language. Also, I noticed this with mature minors. And I read that, I was like, we're talking about children. Why are they calling them mature minors? What does that even mean? But it seems to me there's a shift away from some of the more challenging and problematic language that might actually stop people and get them to sort of reconsider this. Have you noticed a shift in the language or a shift around the control of the language that's being used to describe what's happening?
Yeah, it's a very good observation. And it's one, like, for example, the palliative care community. So Balfour Mount, who pioneered palliative care, he went to England, learned from Dame Cicely Saunders came back. He was a urologist in Montreal, who became one of the first palliative care doctors in Canada, had said, we've always had medical aid in dying, because that's what they called it in Quebec. They called it medical aid in dying. That's what palliative care people do. And I remember that my parents didn't even understand the difference between palliative care and MAID. And that was largely part of the debate. And I don't know if you have ever seen the article. It's by Miranda Schreiber in The Walrus. It's called The Lobby Group That Owns the Conversation. And it talks about how certain very wealthy lobbyists have funded, or well-funded lobbyists have employed PR companies to come up with these terms. Even in terms of forced transfers right now, they're having a court case about everyone has to do MAID everywhere, otherwise it's cruel, and we have forced transfers. Well, we do transfers all the time, but that was a coined term that you could read about in a policy options article by Gabrielle Peters about this kind of language discussion and how we can create arguments and how we can reach people in society. And that's part of what I think is different in the UK debate. They didn't have so much a monopolization on the media and the language. So they're doing, though, what we did here 10 years ago. So, they talk about initially, like what they're talking about here, it was the same discussion that we had here, that this would be an exceptional measure. They said, Gaëtan Barré predicted 100 cases in Quebec, requests per year in Quebec. Now it makes up 7% of their deaths, and they're doing research as to why. And they had said it would be first and foremost a policy of excellent palliative care. I was still at McGill. I was still in Montreal when this happened in 2010, when this discussion happened. And they said that, it would be there would be incredible safeguards to prevent wrongful deaths. And then when it passed, the language quickly shifted. Like, safeguards have become barriers to access. We're almost lost the language of safeguards. You are discriminating against certain groups by not allowing them access. So instead of protecting populations, the language has largely shifted to ones of discrimination and barriers to access. And if you look at the articles that are coming out after Alberta, even though, for example, the National Post and the Globe and Mail, even the Globe and Mail editorial board, they all welcome Danielle Smith's bill for safeguards. The initial articles that were coming out was that Alberta was restricting rights. I was actually at the press conference. A lot of the reporters were framing their questions were like, why are you trying to restrict people's rights? They couldn't even understand that there's an intersection here about safety. And part of that has to do with very smart lobbying.
Right.
We're back from the break, folks, with our guest today, Dr. Ramona Coelho on the Caregivers Podcast. Ramona, I'd like to speak a little bit more broadly about some terms. And certainly, there are many proponents of MAID, and MAID has its place, and it's evolving. A lot of the conversation these days speaks of autonomy and choice. But if people aren't being offered housing, income support, proper mental health care first, is that really autonomy in choice, or is this what you kind of mean when you say when death is given because systems fail to offer support, that is not autonomy, it's actually abandonment?
Yeah. I say abandonment, patient neglect, coercive influences to die. That is exactly how I read it. And suicide. The International Association of Suicide Prevention just released a statement in December of 2025 reminding the world, so they're the biggest group of suicide prevention experts that are coupled with the World Health Organization, that, first of all, that MAID for mental illness cannot be done safely, that we don't have any evidence, first of all, it's guesswork about who will never get better. So when we say it's grievous and irremediable, we're actually guessing, and we'll be wrong more than 50% of the time. But even for psychosocial suffering for people with disabilities, we must not forget the principles of suicide prevention. And so when someone is wanting to die because they have a transient life crisis, And by transient, I could mean a longer transient life crisis. Like some people suffer for a few years. I've had patients with disabilities who, I let medical students come to my clinic to see and meet my patients and to learn. And I introduced them to a lady who had been in the hospital in and out for years. And she does have disabilities. She would have qualified for MAID. And she would qualify for MAID now. But then, though some things change. They change without necessarily systems getting better. And actually sometimes without treatment. Just with accompaniment and something external of medicine helps them. Because community life, meaning these things can often change our perspectives on our will to live. And so 100% I see this as patient neglect. I also see it as like ignoring evidence-based medicine, suicide prevention, medicine, and how we actually can best help the patient.
You've said that MAID is now shifting medicine from treatment of suffering to the elimination of the suffering patient. And what does that do to our medical culture today? And what impact does that actually have on the next generation of physicians? In your discussions with medical students, how is this affecting their vision?
Just because I have been labeled as extremely biased, I'm so careful about talking about MAID to medical students. And it's unfortunate, right? Like, it's like, okay, I don't feel I've been labeled a certain way, so probably that's not something I should bring into the discussion. But I definitely try to focus on vulnerability, on recovery, on understanding, not flattening the patient just to their suffering, to try to understand holistically what is like the total pain. What are all the aspects things that we can offer them outside the gamut of traditional like medications? So I would say that that's my focus with medical students. In terms of rewriting the ethics of medicine, I am really concerned. I did co-edit a book with Trudeau Lemons, who's the bioethics chair at the University of Toronto for the law faculty, and Dr. Sana Gained, who is a professor of psychiatry in Toronto, called Unraveling MAID in Canada. And in that book, we have different chapters from different experts across Canada talking about the problems with the MAID regime. And in one of my chapters that I wrote, I ended saying, I am so worried that, young students who haven't had haven't had the benefit of long accompaniment of patients with chronic issues, not learning that resilience and patience, not learning that we can target suffering. If they see that less than they see MAID, and we have an incredibly high rate of MAID in Canada right now, we're at 1 in 20 deaths are MAID deaths. And for example, with ALS, I wrote an article. A gentleman contacted me that his neurologist told him that he was the only person in his practice who was still alive at his state of disease, that everybody else had MAID. And the Health Canada report mentions that as well, that we have much higher MAID deaths for ALS than natural deaths anymore. And so the question is, when we no longer have that mentorship, or we're not seeing and not having that time to understand how beautiful it can be, how much closure there can be, that there can be beauty on the other side, will this become like the fastest solution? And I can't say that this is my own idea. Harvey Chochnov, I mentioned him before as the gentleman who pioneered existential therapy in Canada. He's also one of like my life mentors and friends. But he wrote an article in JAMA about, is medical assistance in dying really palliative care? And he goes through the basis of what medicine has always traditionally been. And I would say that his article speaks not just to whether medicine MAID belongs in palliative care, which he concludes it doesn't, but is it actually congruent with the principles of medicine, right? Medicine is proportional. We try to really target the suffering and the disease process without hurting the patient. it tends to try to not do harm. Here we're rewriting the whole plan, right? We're ending the person's life because we're saying we can't target the suffering, but actually we're offering missing the suffering. Anyways, this article goes on principle by principle. It's a brilliant article written by Harvey Chochinov and Joseph Fiennes, F-I-N-S, in JAMA, and I suggest everybody reads it.
We were all trained in the biopsychosocial model of medicine, and you alluded to palliative care, and that's probably late phase biopsychosocial in terms of just the whole journey with the patient, right? And if you have a patient for a long time in your practice, it's the natural continuation of the biopsychosocial model. But as you sort of start talking about therapeutic nihilism and all these other things, what strikes me in this conversation is that it seems like there's a halt to the whole biopsychosocial model, and this is going to be the fix.
Yes, and Mark, that's exactly
the biopsychosocial model is something that we've held dear. It's been rooted in our training. It continues to be, yet I think it's almost jeopardized to some extent, unless someone would argue that MAID falls within the spectrum of adapting the biopsychosocial model to the patient in front of you. But I think that's a difficult argument to make, or certainly one that needs to be very carefully made.
Yeah, I couldn't agree with you more. You do chronic care as well, am I correct?
Well, I don't. I look after patients with chronic GI disease.
Yeah.
But I don't do, and I have a large patient population of chronic patients in that specialty setting. Yes.
Yeah.
So when we think about sort of track 2 and how patients are becoming cognizant of their options as they're facing certain situations, and the question is, does the patient bring up MAID, or should healthcare workers even be allowed to raise MAID first in a vulnerable patient as an option amongst the list of other things, or sometimes maybe even at the forefront? I could understand where, nihilism and bias could definitely say, well, there is MAID, early on, as opposed to feeling somewhat defeated at the prospect of everything that needs to be done to take a vulnerable patient out of loneliness, out of, that feeling of lack of community. I mean, it takes time, and it's a process to bring people back from those states, but it is achievable, as you've pointed out, and it is something that we can hold in our sights. Before the patients ask for it, should it be in the scope of what a healthcare worker of any kind should be proposing to a patient?
Yeah, I absolutely think it should not be. In some jurisdictions, it is. So in other jurisdictions, it is often illegal. Like, patients must initiate the MAID discussion and say that they want to talk about it. And in other jurisdictions where it's not illegal, it is really frowned upon to raise MAID. CAMAP came up with a policy called Bringing Up MAID, suggesting that it was very important that Canadians be informed about this if they could qualify. And that has been adopted by the model standard by Health Canada for MAID. I've considered that to be very concerning. Now, these are just professional standards. Alberta has, in their legislation that they've tabled, turned it back to being a patient-initiated approach. And the reason you've touched on it, when we're talking about vulnerability, we talk about medicine and evidence-based medicine about discrimination. And we have a lot of evidence about that doctors and clinicians, unfortunately, we carry the same biases, sometimes consciously, and sometimes very dangerously unconsciously, about racism, sexism. We have lots of disability, ageism. There's no shortage of medical literature that show that doctors tend to just naturally rate the quality of life of people with disabilities much lower than they rate their own quality of life. And so when you think that certain people might be seen as having a life intolerable and that it might be a mercy to end their life, and so that we suggest it, that's problematic. And the fact that some patients get offered MAID many times. I have been contacted by pro-MAID doctors in certain cultures who are really concerned. They're like, I'm pro-MAID, like I have no problem with MAID. they tell me. But, I will approach a patient and they will say, like, if you talk to me about MAID again, I'm going home because you'll be the third person during this admission who decided that somehow I was MAIDable. And that's a very sensitive doctor who's concerned about it, right? They feel that they have an obligation to raise it, but they're feeling that certain patients are having it raised way too many times. And the thing is, there's a power imbalance in our relationship with patients. We have to acknowledge that. When I tell my patients sometimes, like, okay, these are your options, in terms of your values and preferences, whatever, they're often like, what would you do? Tell me, what would you do? Just tell me. And I'm like, okay, look, can we get back to, no, Ramona, what would you do? I'll do whatever you want. What would you do for your mother? I'm like, okay. So, like, there's a lot of respect. There's a lot of power imbalance. And so the thing is, when someone goes to the emerge and finds out they have a new cancer and the doctor is telling them about a MAID, which has happened, what signaling does that send? It sends a message of, like, this is going to be pretty shitty for you, right? I'm terrified for you, and I think MAID might be a good option for you. And I think that's incredibly dangerous.
It almost sounds like it sets up a coercive dynamic for the elderly or the disabled or the marginalized as well.
Yeah, I think so.
Do you think that's a slippery slope?
I think we're there. I think we've, the idea that people would say, like, there's no slippery slope. This is exactly what Carter intended. I find that denialism of, we have enough cases. Now we have, people saying that all the media cases are fake. We have the coroner's cases. But, not everybody in the disability community can be lying. And we have research, emerging research. I can't see how people cannot say that this is a slippery slope. There's definitely been drift. Like, you even have some MAID providers saying in the media that when they hear about a case being approved, well, that changes their approach and they open up their approach more. So what does that mean? That's what I consider a slippery slope, right? When we don't keep the safeguards tight, there's no way to enforce them. We kind of like open up and let more people in, people who are unintended, people that we wanted to protect from wrongful deaths. That's what I consider to be the slippery slope.
So Canada is now preparing to expand MAID, and I know it's been tabled to 2027, but to people with mental illness. But beyond that, Parliament's also even discussing future expansion to children deemed capable of consenting on their own, even when parents may not be consented or may not be providing consent, but rather just simply consulted on. Once a country or a population accepts the principles that suffering in itself, just suffering alone, can justify an assisted death, where does that logic stop? Like, where are the breaks for that kind of thinking, and what concerns you the most about where this could go next?
Yeah, it's very interesting. Scotland has just, I did testify in Scotland. I was called as an expert there, and they did just vote down their assisted suicide law that had been before them. And it was very interesting to see the complexity and the interest in a true debate over in the UK about safeties and where this would stop, and can you stop it once you say that death is an acceptable answering to life suffering? Well, who's suffering? They're framing it as in, like, it's discrimination now. You think that people with, this is what we're hearing over and over again from people who want MAID for mental illness. You are discriminating against people with mental illness. They are also suffering. This is stigma leading to them being excluded. Well, actually, it's the opposite. Mental illness is not like cancer. We cannot predict the few people who will not get better, we can't even know who they are. If you put 100 people with severe mental illness in a room and asked 100 psychiatrists, they would all guess wrongly who that person was. We have no way prospectively.
No biomarkers or
nothing.
Clinical tools.
Nothing. No clinical tools, right?
Level of granularity.
Exactly. In fact, we have all the meta-analyses showing that, all of our top evidence shows that. And yet some doctors in Canada and some lobbyists have said we can do it by consensus. We can just decide that if someone meets these 13 criteria, apparently the CPA is going to come out with a consensus statement based on people's expert opinions. We talk about eminence versus evidence-based medicine. And we're trying to move away from eminence-based medicine because we understand that there are higher levels of evidence. And yet, because ideologically people want this to happen, they are willing to throw away evidence-based medicine and say we can just do this by consensus. Let's forget about the fact that evidence says we'll get it wrong half the time. But really, we're talking about people's lives who would recover and want to live. And if MAID is a medical tool, like if it's been inserted in medicine, then it should obey the same kind of checks and balances that other things have, right? We need to look at the risks and harms to the population, whether this is something safe to implement. And yet all that has been thrown away by a certain small group of people. Like the majority of psychiatrists do not want MAID for mental illness in Canada. The consensus among like the chairs and other statements have all been that we are not able to do this. Like we're not able to actually guess who will not get better. So we'll be killing people incorrectly. Like if the legislation is supposed to really help people who are never going to get better by ending their lives, we won't be doing that. Carter was actually put forth for people who were so physically disabled they couldn't commit suicide. That was the logic of Carter. We're going to help end people's lives as an exception because they can't commit suicide so they can live longer and have someone commit suicide for them when they cannot. How does that logic even extend to someone who is able-bodied and commits suicide? And we don't want people committing suicide. So that's what I have to say about MAID for mental illness. About MAID for mature minors. Our consent laws and capacity laws for children are very different than in other countries that have MAID for minors. I'm not saying I agree with those over either there, but there's a lot of like family consultation. The parents have to be okay with it. The child is usually older. In Canada, we have no younger age, and it's a sliding scale, and it would be the MAID assessor who decides if the child has capacity. So in Canada, for example, we have certain laws restricting smoking or alcohol because we're trying to prevent future harms for our children. But here we're saying that we are going to let children, potentially without their parents' consent, be judged to have capacity on something that is life-ending. And when we talk about, like, they'll say, oh, no, it's just for track 1, Ramona. This is whatever. It's just for track 1. Well, we know that some MAID assessors think that track 1 is okay for people who have 5 years left to live. And the psychological brain maturation is not there for children. It happens much later. So I have a lot of concerns. I've written an article that was published a few years ago in Al Jazeera and I wrote a chapter for the book. This is why I know a lot about MAID for children. I wrote a chapter in that book that I co-edited about MAID for mature minors. And I could also get into advanced requests, but I'm not sure how much time you have.
I really like how you said there's a difference between eminence-based medicine and evidence-based medicine. And, good quality consensus guidelines revolve around breaking things down into some parcels. One is there consensus and how strong is the recommendation? But that needs to always be tempered a bit by the quality of the clinical evidence that those recommendations are being made from. And, a moderate recommendation with very poor quality evidence doesn't change my practice. It's something to think about, but it's certainly not written in stone that that's how that guideline needs to be implemented. So I think it's an important caveat that you bring up. If you could change 3 things tomorrow to sort of stop Canada from offering death where care should come first, what would they be?
Well, I said this in a press conference in Alberta. They asked me, the reporters, one of the reporters asked during the press conference, what would you do that's not on this bill? And I said, well, that's very rude to ask me in front of my guests. Like, they've invited me to do this press conference. But what I shared is that the prognosis of the disease needs to be clear and has to be the driver. So the idea that we're letting people into this MAID regime for, as you mentioned, like housing or financial insecurity for people who have these kinds of sufferings, I think the one legislative safeguard that I have mentioned publicly and written about is having a disease prognosis that is the driver, like some sort of timeline like they do in the States, right? They say like 6 months or 12 months with the disease prognosis causing the death, not making oneself having a natural death by refusing food or refusing antibiotics, but really like having a disease that is going to take you out, unfortunately, in a certain timeline as being the largest safety that you can add to such a bill, to have to such a legislation. And I think that we need to focus as a separate issue. MAID providers always say this is a separate issue. And I guess it is a separate issue, but it does touch on people's choices we need to help people with our chronic care. Our chronic care needs to be better funded, needs to be more timely, needs to be more longstanding. I will share that my sister is a psychiatrist, and she was the head of public health psychiatry for New York City, and then she came and was the lead at one of the psychiatric hospitals here in London. And I eventually convinced her to leave all that and to do OHIP-covered psychotherapy with my patients because they just could not get care. I take care of a lot of refugees, a lot of men out of prison, people who just do not have the financial means to have psychology that is not covered for them. And so she does do medication and she does stuff, but she also does OHIP-covered psychotherapy. It's not fair that I can harass my sister so that I could have that thing for my patients, but that is what all Canadians need. We need to fund mental health care better. We need to fund disability care better. My father, I shared that we got 2 days of palliative care before he died because dementia's prognosis is not so clear. So in January, I was telling people, like, my dad's not eating anymore. He's starting to become like way weaker. His PPS score was too high to qualify for having palliative care services. So it took like multiple hospital visits, stabilizations, bringing him, my husband carrying him around the house. And then finally, they gave us palliative care for the 2 days before he died. Now, me and my husband, my sisters, my 5 children, we got that. Most people don't have that. I consider that to be coercive influences to die. And so I think all of that needs to be heavily looked into. And the third thing is community life. So if you look at mental health outcomes, and I do believe that it is mental health that is driving a lot of people's MAID requests, even in track 1, even in track 2, and obviously will be in track 3. There is a person named Thomas Insel who was the head of the NIMH, of the National Institute of Mental Health, who wrote a book called Healing. And he talks about, with or without medications, what leads to a good prognosis, right? What leads to it is like feeling included in society. It is feeling like you bring other people meaning. Not that you can do things, like our society is like very metric focused and we do this and we do that, but that we belong. And that if we weren't there, it would bother people because we mean something to people, that we like that kind of relational society, relational autonomy. And I think partly COVID, I think partly like this kind of weird politics that makes people feel like they can't talk or connect because they're different. Guess what? We're very pluralistic. We're a very diverse society. But I think that we all have a lot more in common than we don't. And we need to start reaching out to our neighbors and our communities and rebuilding community life after COVID, because otherwise, regardless of MAID, we are going to have an increasing mental health crisis for our young people. So those are the 3 things I think we need to change.
I think we're going to end it there. And with that message that community is so strong and it permeates so many elements of suffering. It permeates elements of caregiver burnout. It permeates medical training. All of these things, a sense of community and belonging, contributing and receiving contributions from your community partners, if you will, brings so much to the human experience. And I just want to take the time to thank you for speaking to us today, coming from your recent travels and with your busy schedule. And I think what we've created today is just an ability to just put it on the table and talk about it. And I really appreciate just being able to talk and listen and hear what you have to say. And I invite everyone to do the same.
Thank you, Mark. And thank you for having me as a guest in what I know is a really can be very polarizing topic. And just to reiterate that I think a lot of MAID people who do MAID do it well. And it's not meant to be about a personal attack, but it's about how we can protect vulnerable people in our society.
That wraps up this week's episode of the Caregivers Podcast. See you again next week. I'm your host, Dr. Mark. Dr. Coelho, thank you for joining us today. This is one of the most difficult and divisive conversations in Canadian public life today. We appreciate your willingness to bring both clinical experience and moral clarity to it. Whatever people think about MAID, this discussion forces a deeper question that no country should be able to avoid. When someone's suffering, are we meeting that suffering with care, protection, and support? Or are we allowing some lives to become easier to end than to help? Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.